Okay, so let's go ahead and get started here with our first section, which is on visual field testing and imaging. We are going to go through a number of case examples using our diagnostic devices in our glaucoma patients. One of the things, though, I think we wanted to start off in the quick discussion is to identify that this is a different era. And as everyone is saying today, it's a new normal. And we have slightly modified protocols that have been impacted by COVID and our patients with COVID. And we have to also adhere to our consensus guidelines for the practice and management of glaucoma patients. So with that theme in mind, you know, one of the things that I've been striving to do over the past several months is to make sure that I am very efficient, very practical, and well documented in my diagnostic testing. So using fundus photography, using OCT, and using visual fields are still the basic guideline testing that I need to do in my glaucoma patients. And yet I want to review that and acquire that in as efficient as manner as possible. Shalini, how has COVID affected your practice and your patients? And do you agree that we need to be more efficient with our patients? And what are we moving towards in the future or currently?
Right. I agree with you, Michael. It's all about, efficiency, less chair time, getting our patients in and out of the office safely, but still getting the valuable information through our diagnostic testing and examinations. And I know you kind of mentioned that getting back to normal, but also heard this idea of maybe getting back to better during this COVID time. And so maybe, moving towards newer diagnostic testing faster, like the 24-2C CETA faster might be something better for us to offer to our patients. And so with the CETA faster, previously I will say I was pretty much doing CETA standard on every patient unless they were unable to do CETA standard due to whatever limitations, then I would do CETA fast less frequently. But after we've kind of gone into this time, I've been doing the CETA faster and have been very impressed with the information that I'm getting back. The CETA faster is actually 30% faster than CETA fast testing. They've gotten basically rid of the false negative reliability. Blind spot monitoring has been replaced with gaze tracking. And all of these modifications have led to shorter time for my patients in the visual field testing. So I think this has been something I'm very excited about being able to have the opportunity to use.
Yeah, I have a quick case example here of a comparison from the same patient who took a traditional 24-2 CETA faster, the new faster algorithm, but then also did on the same test day the 24-2C program that adds in those extra 10 central points to help us highlight the highest risk, if you will, for central visual field defects in our glaucoma patients. And you can see there that the 24-2C test pattern did not add substantially to the test time. We're still just over 3 minutes per eye, and under 3 minutes for the CETA faster in the traditional format on the left side of the program there. So I think you're exactly right there, where initially when COVID hit, it was like, we're not doing visual field tests at all, and we're afraid of everything. Now we have protocols to disinfect the perimeter, disinfect the bowl. We can do it under, with appropriate safety precautions. And we still need to acquire all of this diagnostic testing for our patients.
And I will mention also, there is always a fan running, within that bowl in the machine. And if you keep the door open and allow that ventilation, you can almost think of it as it's just as safe as them being in the clinic with you in the exam room, face to face with your mask on. I think there's definitely less exposure sitting in that ventilated visual field room, and especially such a short amount of time. So. Another reason to kind of switch to the CETA faster. I
think the one tip is to obviously watch out for fogging of the trial lens, and watching out for the position of the mask, and sometimes using a piece of surgical tape on the top side of the mask to decrease the fogging that can sometimes develop.
Completely agree. I'm pretty much having all patients doing that. But again, shorter testing time, less time of that fogging issues, and patients can do this reliably and get your information.
Yeah. Okay, so one of the other themes that I was focusing on in my first section here was Fundus image acquisition. One of the camera systems that I've been using for the past 2 years now is the Claris system from Zeiss. And I really like the wide field and ultra wide field and montage capabilities of this. It affords me an easy way to get a great view of the back of the eye. In addition to my own clinical examination, this obviously is a good reference point. And while there's been so much attention and hype, if you will, on, not hype, that's not the right word, but focus on OCT testing over the past 10 years or so, people have forgotten about good fundus imaging. And when you have a great camera system and you can get a wide field 133-degree image like this in a stereo pair for a patient, and you can zoom in and get stereo disc analysis and, you know, do the things that we are supposed to be doing as ophthalmologists and optometrists and glaucoma specialists, and looking at the optic nerve and using our skill set there to identify change in the back of the eye. It's just really helpful, and also very helpful to be able to get an overview of all the other potential pathology in the retina out to the peripheral retina there. So that's very helpful and very efficient.
I think you make a good point, Michael. I think sometimes we, it's easy to just naturally just go do an OCT on every patient and forget about the fundus photography. But it definitely adds value, and those patients that, you know, to really critically be able to look at that nerve, if you've got the old fundus photos and you can follow up with a new one and see if there's some potential subtle notching or peripapillary atrophy, sloping, then even sometimes, you know, disc hemorrhage that could be picked up that you maybe just didn't see as quickly as the patient blinks. So I think there's definitely value in doing those fundus photography as well.
Yep. Here's the same patient using the caliber measuring system that's included with the Claris. Just in case you need to do that sort of thing, it's available to you. And while I don't typically do a lot of ultra wide field imaging on my glaucoma patients, that is one of the options and features of the Claris system, 200 degrees out in two fundus images here. And if you wanted to do a montage and go further and go more superior and inferior, you can do that as well. And the true color option that the Claris provides is a nice advantage over some of the other systems that are out there. Again, baseline photographs of a patient of mine who is ocular hypertensive. You can see the wide field photos there. The next slide shows right and left optic discs, you know, a relatively small disc and small cupping. Those are sometimes the more difficult ones to judge with early glaucoma's change. There's, you know, a little bit of maybe irregularity around the disc margin and maybe a little bit different in disc size. So while I'll often use my OCT to look at disc size, again, with a good camera system like the Claris, you can actually measure that and see if there's a difference in asymmetry between the overall disc size that would account for a difference in the cup size and the neuroretinal rim area and things like that, and give you more information about your assessment of the overall health of the optic disc. And then this patient who was ocular hypertensive, had been following for a while, and my slide here is just to reiterate that, you know, when everything is integrated together, and I think that's a real, you know, important aspect for eye care practitioners to think about the integration of their diagnostic devices so that they can assimilate all the data together, integrate all the data together from even different instruments and in different companies when necessary, so that you can get a good overview of the fundus photo, visual field, RNFL, and ganglion cell map area, so that you can identify where change might be developing in these ocular hypertensive patients. Next example is, again, a Claris photo, wide field and stereoscopic, of a patient with very advanced glaucoma. You have the ability to zoom in and look very carefully at the optic disc and very thin neuroretinal rim. You know, of course, documenting end stage or advanced stage glaucoma is not always necessary, but having this in the patient's library of diagnostic imaging is often helpful down the road as our patients are living longer and longer, and, you know, we need something to refer back to really identify if there's any change of the optic nerve or in the retina. Next example here is of a wide field photo of a patient with glaucoma and a disc hemorrhage. And it's just identifiable there at the 7, 8 o'clock position on the disc margin. And then I highlighted with annotations from the Claris camera where the disc hemorrhage is and what I identified as an area of retinal nerve fiber layer dropout that I seemed to identify based on the loss of the reflection of the retinal nerve fiber layer there. And putting everything together, structure function analysis in the forum viewer layout allows me to identify these high-risk patients with split fixation visual field. Is it progressing? We'll use our progression analysis, of course, and set lower target pressures as I identify these patients with very severe disease. Some individuals may like a different report that you get out of the forum viewer software, and that's called the combined report. It depends on what type of layout you like and how the practitioner likes to review the data. You're able to put right eye and left eye together and put the fundus image, OCT, and visual field. So using all of this data together really helps us make our decisions more easily and more efficiently. This 60-year-old patient with ocular hypertension knew he had ocular hypertension for a number of years, skipped appointments over a couple of years, unfortunately, and then was at home one evening doing crossword puzzles and happened to cover his left eye. If you look carefully there on the photograph, you can perhaps identify a superior temporal region of nerve fiber layer loss. And he happened to identify a scotoma on the crossword puzzle in his right eye, some distortion that he noted just by happenstance. He came back in. We took the photograph that I just showed you. We did a panomap, which is a stitching together of the retinal nerve fiber layer and ganglion cell OCT scans. You can see the significant loss there. And then the 24-2C test pattern showing central field loss in the inferior arcuate region for this patient with what used to be ocular hypertension and now obviously is moderate stage glaucoma. Another example of a glaucoma suspect with stereo disc photographs. Again, just sort of the baseline for, I'm in a teaching academic institution here, teaching my residents and students that, despite OCT and how great it is, and despite the wonders of visual field testing and everything else, looking at the optic disc is still what our bread and butter is. And doing it with photography is a really great for the practitioner and really great documentation for the patient. This patient shows some nerve fiber layer loss inferiorly in the right eye, as you can see on the panomap report there, and maybe just the earliest of signs that are starting to show up on the visual field with a couple points in the nasal region and then a point just paracentrally, superiorly, and maybe that's an artifact point inferiorly. I would like to follow this patient up with a 24-2C pattern in the future. And my last example here is of a 48-year-old with pressures of 35, again, wide field photos, the ability to zoom in on those photos and look very carefully at the optic disc, neuroretinal rim, retinal nerve fiber layer, disc margin, look for disc hemorrhages, peripapillary atrophy, the things that you can't see on OCT. And then, of course, follow it up with a CETA FASTER 24-2C test pattern, as well as your panomap reports from the Cirrus OCT. So again, my gist here and main points I wanted to make was using wide field and ultra wide field imaging to increase our efficiency in documenting the optic nerve in glaucoma patients, identifying those things that sometimes are not seen on OCTs, and also having good baseline images for moving forward. Visual field testing remains essential. Shalini, you're going to show us more of that. And also I showed you some examples of the OCT, retinal nerve fiber layer and ganglion cell layer change.
Okay. So with this patient, obviously I did a visual field, and the right eye basically has some non-specific changes. The left eye has non-specific central defects. So this year I followed up instead of the CETA standard with a CETA FASTER 24-2. And we can see here that with the CETA FASTER, as I explained earlier, it focuses also on some central points that you can get a greater information about the visual field defects in that area. in this case, we have basically, again, non-specific changes in both eyes, but I can feel more reassured that this patient can be continued to be followed as a glaucoma suspect and does not require any intervention at this time.
That's a great example, Shalini. Thanks. That's the 24-2C giving greater confirmation. I agree. Thanks.
So in the second case, I have a 47-year-old Asian male who's being followed for low tension glaucoma. You can see in the right eye greater than the left. He also has a history of high myopia. Highest pressure is no greater than 19 in both eyes. Thinner corneas. His cup to disc ratio, you can see in the right eye about 0.775 with peripapillary atrophy, inferior sloping. And similarly in the left eye, slightly smaller, a cup to disc ratio with peripapillary atrophy, and a typical disc that you would see with myopic in a myopic patient. So I followed up with the visual field testing, and specifically in this right eye, he had significant visual field defects, superior nasal step, split fixation superior arcuate. And because he was not tolerant of any medications or sufficiently responded to any of the medications, I went ahead with angle surgery, gap procedure in that right eye. Unfortunately, he did not respond to the surgery. He had elevated pressures, ischemia of the iris, and then this required an emergent procedure where I performed a phaco with a toric IOL. Pupiloplasty was done with one of my cornea colleagues, and then a Barvelt for the elevated pressure. So you can imagine that this patient's already been through a lot in the right eye, and now we've been following the left eye as well, obviously. You can see in the OCT, so the right eye has the superior and inferior thinning, inferior greater thinning, corresponds to the visual field defects that we saw previously. And in the left eye, you can see over the progression analysis from 2016 to now 2020, he's developing more of this wedge inferior defect. And this also is seen on the ganglion cell analysis in the left eye there inferiorly. You can see some thinning. And again, the right eye, the diffuse thinning. So it's very critical that we're following his visual fields closely because, one, he's very young and he's already had significant visual defects develop in the right eye. So this left eye, we've been following with the CETA standard, and you can see in April of 2019, he's got some superior close to central defects, not the most reliable test with the higher fixation losses. And the testing is taking about 5 minutes, a little over 5 minutes. And then again, it's followed up a few months later, similarly, not the most reliable test. So this year I decided to go ahead with the CETA Faster 24-2C. And you can see those central points that do confirm that there is essentially a shallow defect there. But again, this is a test now because it's only taking about 2.5 minutes in comparison to the 5 minutes that I've previously been subjecting this patient to. I can feel very comfortable in having him coming back, especially during this COVID time, to do more frequent follow-up testing. So we can both feel comfortable and confident that if there is a confirmed defect, then we should go ahead and do surgery. And if there's not, then we can comfortably follow him because he's stable and that central critical area is being monitored closely. So shorter testing time, more reliable test, and greater central points are kind of the key with this 24-2C. So on our next case here, I have a 87-year-old white female, history of thyroid eye disease. She had decompression done 2011 in both eyes. She underwent cataract surgery. She developed residual angle closure glaucoma in the right eye, very elevated pressures, and she's currently on maximal medical therapy. You can see that OCT is consistent with the very significant thinning in the right eye. And then in her left eye, she has superior and temporal thinning. On the next slide here, you can see that she's got enlarged cup to disc in that right eye, some pallor, and her vision is consistent with that 2100 vision, and her left eye, her good eye, she's 20/25 and a moderate cup to disc ratio over there. You can imagine that this woman lives on her own, she's independent, she's relying on this one eye, and she's 87 years old. And I think, as Michael had mentioned, we've got patients who are living well into their 90s. So she needs good functional vision for, potentially another decade. When we're doing the visual fields, it's critical that I want to make sure that the central vision is stable and maintained. So you can see that this is, from the glaucoma workplace. The nice thing about the glaucoma workplace is that I think even for patient discussions, Michael, I don't know if you've been kind of pulling that up when you're talking to your patients when they come into the exam room. I think it's been really helpful in the discussions compared to what I previously was doing, but I can really very easily pull that up, show them over the last 5, 6, however many years I've been seeing them, that this is what your visual field has looked at like in the, in this eye, and how the progression has been. And they can easily see that, the dark areas are their visual field defects. So you can see that I've done CETA standard in this left eye, her good eye, and she's got an inferior arc, inferior nasal step. And, the previous test that we did, now she's 87 years old, and it was in 2019. She had some excessive high false positives. And then now I just did this past month the CETA Faster and the 24-2C, and you can see that the inferior arc is present with the nasal defects, but the central area has maintained and remained stable. So we can feel confident, again, just monitoring her. And even though she's on maximum medical therapy, we don't need to have a discussion at this moment about having to do surgery. Michael, what are your thoughts on the discussion part and educating patients?
I think it's so important to have large monitors in the exam room so you can show these things to patients, because we can talk all day long till we're blue in the face, and the classical picture's worth 1,000 words. And whether it's the trend line analysis and a negative slope for the VFI, or the grayscale getting worse, and you can apply the same principle to the OCT GPA analysis and everything else. So, we need large monitors to analyze our data, and we need them to show to our patients, and it just saves a lot of time. I usually have my residents and students get that up on the monitor in the exam lane, so when I go in to speak to the patient, it's ready for me to show to the patients.
Yeah, no, I think that's a great point. You were saying about the slope on the visual field index, and you can see here, this is this patient on the left eye, and it can kind of give you a prediction based on their rate of progression, where they may be in 5 years. So again, the rate of progression here is less than 1 to 3%, plus minus, and you can say that she should be able to maintain good functional vision for her lifetime if things stay the way that they're going right now. So again, another education. I mean, definitely with our glaucoma patients, it is all about education, because they can't feel the pain. They don't know what's, exactly, they can't appreciate why they're taking these drops unless if you can show them in a tangible way.
Right. And with the increase of diagnostic testing, increased frequency of visual fields, as you said, if you don't show the patients the results, then I sometimes wonder, they don't know what I'm doing with that data. They don't know why I haven't come into the room for 5 minutes because I've been analyzing it in another room or whatever, whatever your workflow is. So being able to show the patients these results is just really great patient education, as well as in my environment, academic information for my students and residents.